What is CAR-T therapy? What does CAR-T mean? Well, it's a type of cell. So this cell has been genetically edited by us, a special type of cell. So, actually it comes from the patient's own. So it's the patient's own cells ultimately turned into a fighter, reinfused back into the patient to have this anti-myeloma effect. Its actual name, some patients jokingly call it CAR-T, vehicle, but it's not the vehicle CAR. This CAR doesn't mean vehicle CAR. So it's chimeric antigen receptor T cell. That's its name. Which multiple myeloma patients are suitable for receiving CAR-T therapy? Because it's regulated as a drug, so it's similar to drugs, there's a corresponding indication. The indication here states that adult patients with relapsed/refractory multiple myeloma who have received 3 or more prior lines of therapy are eligible. Of course, like this, for example, for some high-risk patients, can we perform consolidation therapy in the second line or even in the first line? I think if there's confidence, able to manage the corresponding indications, and if the patient has no other suitable treatments, it's also worth exploring. Then, secondly, because CAR-T, during the entire infusion process, there may be a risk of infection, and cardiac and pulmonary function. There may be some high fevers, so for cardiac and pulmonary function, whether there's infection, there may be some requirements. And then, there's also an evaluation of the disease, because CAR-T patients may subsequently develop hepatitis B virus reactivation, which is a very deadly complication. Therefore, it's best to not have active hepatitis B. Others, including pregnancy and gestation, women planning pregnancy are better off not using it. Of course, there are also allergies to CAR-T components, and so on. I think before you undergo CAR-T therapy, your doctor will definitely conduct a thorough assessment of this area. The optimal timing for multiple myeloma patients to undergo CAR-T therapy. So what is the best timing? Actually, if the tumor burden is lower, for CAR-T therapy, its CRS, or cytokine storm, might not be as severe. This would be better. However, actually, for patients who can receive CAR-T therapy, I think for the majority, the tumor burden is relatively heavy. It's possible that not all of our patients can achieve the low tumor burden that we want. The safety is very good, so at this time it might need to be based on the specific situation of each patient to try to achieve a lower tumor burden as much as possible. Then, the disease is relatively stable and organ function is relatively good in such a state. Of course, for example, if the patient is already in the advanced stage of the disease and platelets are very low, but we don't have other options, then in this situation, taking the risk might be the only straw to save a life. Is it possible to use it? I think it should still be possible. As long as you dare to take the risk, because if you don't take the risk, you might have no chance at all. So I think before CAR-T therapy, although we say we try to achieve a very good condition of the patient's disease and body, but specific to each patient, we can only say to try to achieve this as much as possible. What assessments are needed before CAR-T treatment? So, before the treatment, we need to conduct scheduled collection of physical examinations, assessment of vital signs and physical fitness, and also PET-CT scans. Moreover, there are some tests regarding extramedullary plasmacytoma, as well as cardiac ultrasound examinations, electrocardiogram tests, and since this is a CAR-T therapy currently on the market, it targets BCMA, which stands for B-cell maturation antigen. So, ideally, the patient's cytology and plasma cells in the bone marrow should express the BCMA target. Additionally, there should be an expected survival period of more than 12 weeks. Of course, as I mentioned earlier, if there are no other available treatment options, and the patient is willing to try, then I think it's worth a shot. Of course, in laboratory tests, this includes a series of these tests. I think your doctor will provide you with prescriptions. Unveiling the full process of CAR-T therapy for myeloma single collection. What everyone might be most concerned about is this process. How exactly is the process done? One thing is, for example, this patient, we're getting ready to do CAR-T for them. The evaluation says the patient's disease requires us to perform this CAR-T therapy. At the same time, the BCMA target also exists. So, we'll first admit this patient and collect peripheral blood. So, this peripheral blood collection compared to what we do, many patients have had autologous transplants. Before autologous transplant, there's also a lymphocyte collection. But this time it's shorter because it needs to. Sometimes we need to collect for 3 days for autologous transplant, but for this, basically, we collect once. It takes about 1 to 2 hours. So, specifically, how long to collect and how much blood to circulate? It's calculated based on the number of lymphocytes you have at the time. We'll calculate a number to tell you how much to collect. So, when this is done, after collection, there are logistics personnel waiting here. They're already waiting outside this collection room. As soon as your cells are collected, it's immediately handed over to the logistics personnel. These logistics personnel then quickly, whether in Beijing, they might need to take a high-speed rail to transport it to this workshop. Because their plant is not in Beijing, it's transported to the workshop. After simple quality control in the workshop, it will be cultured. During this culturing process, for the cells, there's a series of processing. So, the whole process from collecting cells to reinfusing them, the longest time under normal circumstances, we have to wait for 2 to 3 weeks. Then it depends on when it's ready, whether it can be released. So, it's not like you can prepare it immediately after collecting it. Prepare it and immediately get it back. It's not like that. It's not plug and play. It's not like it's ready to use. These cells, this is also a current, possibly a major obstacle for this treatment. So, there might be some patients, because in this process, the cells aren't active enough. They didn't grow. So, there's a possibility of failure. Revealing the full process of CAR-T therapy for myeloma. Bridging therapy. So, during the patient's waiting period, we collect lymphocytes. Especially for us, to improve the function of lymphocytes, we might previously stop all these myeloma treatments so that the lymphocytes are not affected by these, such as our CT38 monoclonal antibody, our steroids, even our lenalidomide, our bortezomib. All can affect your lymphocytes. If these are stopped, the patient, often by the time they need CAR-T, may already be in a dangerous situation. So at this time, the tumor burden might have increased, and you might need to consider whether to undergo a bridging therapy. If the tumor burden is high, then after infusing CAR-T, it might cause CRS, which is our cytokine release syndrome, to be quite severe. So after a bridging therapy, we can reduce the tumor burden, and CRS might also decrease. So at this time, bridging therapy is not needed for all patients. Based on your doctor's judgment, whether you need bridging therapy. Unveiling the full process of CAR-T treatment for myeloma lymphodepletion. We will perform lymphodepletion 5 days in advance. Lymphocyte depletion. This means we will slightly suppress the function of your lymphocytes. Just a little bit. So that the infused lymphocytes will not be rejected by your body. Nor will they trigger an immune response against them. We need your lymphocytes to calm down first. Quiet down. Then, we will infuse the prepared ones. In general, we use fludarabine in combination with cyclophosphamide for lymphodepletion. Usually, this involves a 3-day infusion. The reaction is generally not severe. Many patients ask, will I feel very uncomfortable from the chemotherapy infusion? It's manageable. Some patients may experience a slight headache. Unveiling the full process of CAR-T treatment for myeloma, reinjection. We will send the prepared CAR-T cells back to the hospital. Different companies may have different procedures. For example, we have sequential CD19 and BCMA treatments. It may involve multiple bags. So we might infuse CD19 first, then BCMA. For IASO's BCMA CAR-T, it usually involves just 1 bag. Once it's infused, it's done. Different companies' CAR-T treatments might have different preconditioning reactions such as fever and CRS. These might vary as well. Then we infuse the cells. Before infusion, we might give some calcium gluconate and some promethazine. I am particularly sensitive. Every time they infuse cells, I can smell it. There is a cryoprotectant inside called dimethyl sulfoxide, DMSO. It smells like rotten tomatoes. I don't know if some patients are as sensitive as I am and can smell it too. Anyway, every time I smell it, I think, oh, a patient in this room is probably getting a cell infusion. There usually aren't many other reactions. The infusion process is generally safe. Unveiling, the full process of CAR-T therapy for myeloma monitoring. We generally monitor the patient, ECG monitoring, blood pressure monitoring. Hospitalization, for 7 to 14 days. For different patients, the timing of their fever and the occurrence of cytokine release syndrome, CRS, may vary. Moreover, different manufacturers, even though they all produce BCMA CAR-T, because of their gene editing techniques and methods, there might be some differences. For example, their co-stimulatory signals are different, and the inserted gene fragments are different. This all leads to the fact that although they are all called BCMA CAR-T, in reality, the CRS response and fever can be quite different. What should be noted when reinfusing CAR-T cells? So, during CAR-T reinfusion, one thing is the general condition assessment. And also before reinfusion, we usually administer some acetaminophen and antihistamines. After taking these, the patient will be very drowsy and just want to sleep. Tocilizumab is used to treat CRS. We keep it ready in the ward, available in the pharmacy there. Additionally, it's best if all patients needing CAR-T infusions have ICU support. Because there are extreme cases where CRS can occur suddenly after the infusion, causing blood pressure to drop and affecting respiratory and circulatory functions, or even central nervous system issues due to cytokine storm affecting the central system, leading to sudden death. So in the whole process of reinfusion, our overall support is very important. Another thing is that after lymphodepletion and in the late stages of multiple myeloma, many patients are in very poor condition. At this time, white blood cell count may be low, and after FC preconditioning, the white blood cell count may further decrease. At this time, GCSF can be used, but try to avoid using GM-CSF. In this way, it may reduce the risk of CRS. How to monitor after CAR-T cell infusion? During this process, we should monitor the expansion of CAR-T cells for their proliferation and also monitor various cytokines, including IL-6, IL-10, TNF-alpha, ferritin, CRP, and others. Through these, we can determine the patient's level of CRS, cytokine release syndrome. If the IL-6 levels are very high, we must decisively intervene. Additionally, for CAR-T cells, there is a loose kit which can monitor their expansion. Additionally, imaging tests and bone marrow examinations. What are the adverse reactions after CAR-T cell reinfusion? I think the most critical issue is the adverse reactions. These adverse reactions require both doctors and patients to have a clear understanding. The most common adverse reaction is probably fever. The CRS, cytokine release syndrome, of different products varies. For the IASO bio product, because it is a humanized CAR-T, its CRS is relatively mild. Severe CRS occurs in about 5% of cases. With emergency treatment, all can improve. Another issue is ICANS, immune effector cell-associated neurotoxicity syndrome. This ICANS generally occurs 3 to 6 days after CAR-T infusion and lasts for about 2 to 3 weeks. Of course, there are some other rare side effects, including immune cytopenias. We had a patient with a prolonged low platelet count that lasted for 2 to 3 months before gradually recovering. Recovery began gradually after administering steroids.